errors are 3. Are you able to hear me? Please write in the chat box. Tanima Dwivedi, please unmute yourself.
Hello, good morning, sir.
Good morning, Tanima. Where are you from?
Sir, I'm from NCI National Cancer Institute.
Okay, right. Acha, can you see this slide, Six Sigma?
Sir, I can see the main slide, the topic.
Topic. And now I have changed the slide. Is this
Yes,
change
sir.
visible?
Yes, sir. Yes, sir.
Okay,
Yes,
and
sir.
I'm clearly audible.
Yes, sir.
Thank you. So that means out of 1000 opportunities, possibility of errors are 3. And if we apply this concept to Six Sigma, Six Sigma means out of 1 million opportunity, chances of errors are 3.4 only. So this is the utility. In this way, we are able to quantify the quality in different scenarios, whether it is some outcome, it is process or procedure outcome, or it is variation in our data. How we apply this, that we will see. First, we will see why it is important to develop quality, to assess quality, and to quantify quality. See, 70% clinical decisions are based on our reports. But we want, in our laboratory, we want to release error-free report, which is meaningful for clinician. They can make correct diagnosis, they can start correct treatment, and as a laboratory person, we are contributing in the better patient care. For this, we tell our clinician, you will get correct report and that correct report within reasonable time frame. When we are assuring them, they may ask, what is the basis of this assurance? How you are assuring us? We are saying, see, we are following quality control in our laboratory. Not only in examination, we are running IQC, we are participating in a class. In pre-examination, examination, at every step, we have good control over our quality. And this quality, for this quality control, we have developed our quality management system, which is based on international standard, that is ISO 15189. Now, they may say, yes, you have developed your quality management system. It is okay. But what all you are doing in this quality management system? See, we are taking good care of our pre-examination, examination, post-examination. These are the different clauses of ISO 15189. This I am showing you just to emphasize upon the fact that this 15189 is very important to develop quality, and we have to understand this we are developing for our laboratory, not for any accreditation body. And how we are carrying out, how we are improving in this area. See, whenever there is any complaint, any non-conforming work, or certain evaluation, see, whatever I am showing you, you can apply Six Sigma at each step. The resolution of complaint. Suppose 50,000 patients are visiting to our laboratory in 1 year. Out of these, and how many complaints we have received? Suppose we have received 36 complaints. So that means out of 50,000 patients, 36 have lost their complaint. So we can convert this into Six Sigma, or we can do it on monthly basis. Then we can analyze our data. These complaints are reduced, so our Six Sigma has improved. Closer it is to 6, better is the situation. That we will understand little later. But what I am telling you and why I am showing you all these things, we can apply Six Sigma to any situation. We are developing good quality management system, and for various processes and procedures, wherever there is some outcome, we are applying Six Sigma. Wherever there is some variation, we are applying Six Sigma. See, this is the process in our laboratory. Every laboratory has the same process, whether it is good laboratory or not so good laboratory. But process remains the same. What happens in good laboratory? In good laboratory, you have documented procedure at each step. In good laboratory, you have documented procedure at each step. And you can evaluate these steps if you are finding some challenge, some compromise in the receiving of samples, some errors. So how many errors you are receiving, how many samples you are receiving, you can convert that into Six Sigma. How it is to be done, that we will understand. But again, I'm emphasizing on the fact we can apply Six Sigma to any situation and we are able to quantify our quality. When we are saying we are improving in this area, so we can talk with data. This is a powerful tool to assess the method quality, for equipment comparison, and for optimizing QC procedures. How many controls we are running, how frequently we are running, what all rules need to be applied. For everything, we can apply Six Sigma. This tell you, as I said, process variation or process outcome, two situations. And with this, we are able to judge the performance of a laboratory. If we apply Six Sigma to various situations and we want to compare performance of 3-4 laboratories, we can do that based on their performance in Six Sigma. Because when we evaluate, there is a lot of subjectivity. What we need objectivity. As I said, Sigma is standard deviation. We count errors. We convert these into defect per million opportunity. Suppose there are 10 errors in 1 lakh samples. That means 100 errors in 10 lakhs. 10 lakhs is 1 million. So whatever number of data point we have, whatever errors we are getting, we convert the data point into million, and similarly errors are also converted into this appropriate number, and then we calculate sigma matrix. If defect per million are 3.4, then sigma matrix is 6. If 233, sigma matrix is 5. If 6210, sigma matrix is 4. 66807, sigma matrix 3. More the defect, less is the sigma number. So that means if defects are decreasing, sigma matrix will increase. Or if we are comparing in a process sigma matrix of 3-4 different laboratories, so with the sigma matrix, we can evaluate the performance of those laboratories in that particular aspect. So there is a calculator on you will find on Google, which converts defects per million into sigma matrix. If we want to see process variation, one thing is outcome, another is variation. If we want to see process variation, see what we do. We participate in IQC, we participate in EQUAS. With IQC, we are able to judge our precision, how close results are to each other. With EQUAS, we are able to see accuracy, how much it is deviating from the true value. If suppose a clinician is asking, can you tell me whether you have improved in the last 1 year or not in your TSS? Suppose your top management is asking. Now you are saying we are participating in EQUAS, we are participating in IQC. In EQUAS, we have reduced our errors, but there is not significant reduction in the EQUAS, or there is improvement in the EQUAS, but not in the IQC, or there is these many outliers in case of uric acid in EQUAS, but not significant outlets in IQC. They will not understand all these things. They are interested if suppose some endocrinologist is talking to you, whether the report of prolactin or the report of TSH is reliable or not. If there are 3-4 options, what is the best laboratory to send my samples? Or they are saying, last year we have installed a very good machine, then over a period of time, whether the performance has increased or not. So for this, we can use 6 sigma. And when we are using 6 sigma for this, we have to calculate bias. Variation between the true value and the lab result. And generally for true value, sometimes we take group mean, lab result minus group mean divided by group mean. So you get bias percentage, how much it is deviating from the group mean. And standard deviation divided by lab mean into 100, it is providing you imprecision in terms of CV percent. So with this two, you are getting bias percentage, that is accuracy, and CV percent, that is precision. As I said, we use this 6 sigma for process outcome. For this, we use defect per million opportunity and then convert it to 6 sigma. For process variation, we calculate bias percentage and CV percentage, and then we convert that into 6 sigma. In both these cases, we convert to sigma matrix. Same thing I'm repeating again, because why I'm repeating? Sometimes in a particular slide, we are not able to understand, or our concentration deviates. So if something is repeated 2-3 times, then we get better understanding. Number of defects converted to TPMO, and then these are converted to sigma matrix. This sigma matrix we can apply in any situation, whether it is pre-examination, whether it is examination, or it is post-examination. See, venipuncture failure. How many samples you are receiving? How many venipuncture incidences are there? So these are defects per million opportunity. We are converting this into defect per million opportunity, and we are calculating sigma matrix. We can calculate sigma matrix for a particular quality indicator. We can calculate sigma matrix for the pre-examination in totality. Same is true for examination. How many errors we are observing in EQUAS in January, in February, in March, in April. Then we are converting these into defect per million opportunity. Suppose you are participating in EQUAS for 50 parameters and 3 outliers. We can convert this into defect per million opportunity, sigma matrix. Then we can evaluate over a period of time, in last 1 year, how our EQUAS has behaved in EQUAS in totality. Or in 1 year, how many times glucose has shown outlier, and how many times uric acid has shown outlier. So what are the total opportunities? 12. If suppose you're receiving 1 sample per month, out of these, how many times it has resulted in outlier? So we are converting that to defect per million opportunity and sigma matrix. Sigma matrix is a tool. How to use that tool, that we have to see. Similarly, for post-examination, but I am emphasizing again, we can apply Six Sigma in any situation. So what I said, for process outcome, we calculate defect per million opportunity, and then we convert into Six Sigma matrix. For process variation, we calculated bias percentage and CV percentage. Bias from IQA, CV percent from IQC. Then for every analyte, you will get total error allowable. You can go to this Dr. Westgard website. In this website, you will find some guidelines by CRICOS. They have provided total error allowable for various analytes. The total error allowable, this you are not calculating in your lab. It is provided to you through data. Total error allowable is you are getting from that website, CRICOS guidelines, and you are calculating in your lab bias percentage and CV percentage. Total error allowable minus bias divided by CV. This will give you sigma. Now look at this formula. If bias is high, if there is problem in the accuracy, variation between the laboratory value and true value is high, this TEA minus bias will decrease. So it will result in decrease in the sigma value. If imprecision is increasing, that means CV value is increasing. Because this is a denominator, again it will result in decrease in the Six Sigma. If there is problem in the accuracy, or if there is problem in the precision, so Six Sigma will decrease and quality of that analyte has decreased. Then we will see if suppose bias is increasing, CV is increasing, so you may say then sigma will not be affected. But what is the solution for this? That we will see. And generally we say in different industries, for different activities, there are different minimum acceptable performance. For healthcare setting, they say a minimum acceptable performance is 3 sigma and world-class performance is 6 sigma. You may be wondering, this 3 sigma is very less. But we have to understand what is the meaning of 3 sigma. What is the meaning of 3 sigma? 3 sigma means out of 1,000 opportunities, chances of errors are 3. That means if you are collecting 1,000 samples in a month, in only 3 cases, you are getting venipuncture failure. Generally, people accept this. When we say 3 sigma, it is not something which is very less. And for different situations, you have to see what exactly you are achieving, and with time, laboratory shall improve in that. When we were discussing sigma matrix, we said total error allowable minus bias percentage divided by CV percentage. So I said, if suppose bias is increasing, CV is also increasing, you may find sigma matrix within acceptable limit. But when we are using sigma matrix, we have to calculate this quality goal index also. If this quality goal index is less than 0.8, it is indicating imprecise. If it is more than 1.2, it is indicating inaccuracy. If it is more than 1.2, that means bias has increased. If it is less than 1.8, that means CV has increased. If it is 0.8 to 1.2, that means both are increased. And we apply, we calculate this quality goal index when 6 sigma matrix is less than 3. That we will see. So that means we have to calculate sigma matrix, and also we have to calculate quality goal index. Don't think it is something very complicated. What I want to emphasize upon, on x-axis, horizontal axis, we have plotted imprecision, percentage CV. On y-axis, this vertical line, we have plotted percentage bias, inaccuracy. If inaccurate bias is less, if bias is less, if bias is less, CV is also less, so you will get data point close to 0. Closer it is to 0, better is the quality. As it is deviating away from this 0, either horizontally or vertically, or both, quality is decreasing. You can see in this. If it is towards 0, then quality is world class, and it becomes unacceptable when it is deviating from the 0. Now I will show you with some data application of this Six Sigma. See, what we did, we analyzed 10 parameters of internal quality control for a period of 6 months. Albumin control for 6 months, SGOT, SGPT, calcium. First, number 2 is SGPT, then number 3 is SGOT. Calcium, creatinine, glucose, magnesium, potassium, total protein, urea. This is our CV percentage for the 6 months. We also calculated bias for the same period. From our EQUAS report. So after that, we got average CV percent and average bias percent. Then what we did, we took the total error allowable from the EQUAS guidelines and we created this table. What we need for the Six Sigma, total error allowable, bias percentage, and CV percent. So we plotted this total error allowable, bias percentage, CV percentage. And we calculated Six Sigma score. And we also calculated quality goal index for these different parameters. Then we evaluated this data. We observed above Six Sigma, SGOT and magnesium, 5.9 to 3.9, 3.0, albumin, SGPT, calcium, and urea. So for this, we were not bothered because we said if it is more than 3, it is acceptable to us. We observed less than 3 sigma in creatinine, in glucose, in potassium, and in total protein. Then we analyzed what is happening here. In creatinine, it is 0.6. That means there is imprecision. So like that, we observed what happened in case of creatinine, in case of glucose, in case of potassium, in case of total protein. See, creatinine, glucose, potassium, total protein. Where the Six Sigma score was less than 3, there was quality goal index 0.6, in one case 1, 1.2, 1.0. So as we discussed, if it is less than 0.8, it indicates imprecision. If it is more than 1.2, it indicates inaccuracy. If it is between 0.8 to 1.2, it indicates imprecision as well as inaccuracy. So we have to take appropriate action after analyzing our data. This Six Sigma is very useful in analyzing our data. So if we start applying this, so it will definitely help us in improving quality in our laboratory. And we can use this Six Sigma matrix in deciding about the number of controls also. I will not put more emphasis on this because you have to follow whatever NABL is, if you are going for accreditation, whatever NABL is writing in their 1.1, that you need to follow. Otherwise, if suppose some laboratory is running two-level control once a day, or two-level control twice a day, and they are finding their Six Sigma is more than 6. And after some time, suppose they are saying we will perform two-level control twice a day, in one day. Another day, we will run two-level control in the morning and one-level control in the evening. If even after that, performance is not decreasing, then they are further reducing the number of control. So that way they can reduce their burden, they can reduce their cost without any compromise in the quality. So this Six Sigma is a very important tool in deciding the number of controls we are running. But again, as I said, I will not put more emphasis on this because what you need to follow, whatever NABL is writing in their 1.1. If suppose there is some error, and this is something which we have observed, which need corrective action, you may find some error in this. If there is change in the reagent, change in the control, weekly or monthly maintenance due, date and time of current calibration, if there is calibrator lot change, any maintenance service done, any lamp change, lamp deterioration, reagent shelf, or onboard stability, date of reconstitution of the control. So if a systematic error is detected, that means error on multiple times. So you have to see anything out of these has happened in the laboratory or not. Status after repetition of the control, correlation of lab mean NSD with peer group mean NSD. Suppose you are using a particular machine, you are using a particular lot of calibrator or control, so you are finding something unacceptable. So you can ask your friends who are using the same machine, same control, so what they are getting with that particular lot of control. If a random error is detected, this we discussed. If there is systemic error, random error, proper mixing of the control, any bubble noted in aliquot, shelf life of reconstituted control. Before reconstitution, it may be 1 month, but after reconstitution, it may be 1 week only. Temperature, humidity of environment and instrument, calibration status, electricity fluctuation, some reagent lot change, any instrument error. There may be some blockage in the aspiration tube, some leakage in the aspiration tube. Status after repetition of the control. If everything is okay, then probably that was a random error. As we were discussing previously, we use this as we were discussing, we discussed in the process variation. In process outcome, as we discussed previously, it can be applied in pre-examination, examination, and post-examination. What is important? If we want to improve in some area, so we have to change our practices. This applies to every situation in our life. If you want to improve your health, so you have to live your sedentary life and you have to move towards exercise. You have to shift your dietary pattern. If you want to reduce weight, you want to feel more active. So similarly, in our laboratory, if our quality practices are not up to the mark, we have to include certain things and we have to see how we are monitoring, how we are evaluating. Lean concept is, what is lean? When we say a person is obese, a person is lean. In a lean person, extra fat is not there. If you are removing extra fat, a obese person becomes lean. Similarly, they are using this term in the laboratory. With this lean, with this sigma, you are improving quality, and with this lean concept, you are removing wasteful expenditure. What happens when you are applying lean concept? You are finding out certain areas where a improvement can result in increase in sigma metrics, increase productivity, increase acceptability of the consumer, and increase in the reputation. Obviously, the laboratory will feel happy, and there is decrease in the redo and repeat. Less inventory need to be maintained, less turnaround time. This is good for clinician and patient, and analytical time also decrease. So this is happy situation for the laboratory. So this is lean concept. You are removing wasteful expenditure. As I said, we discussed some statistics in case of process variation, where we analyzed our biochemistry data. Now we will see process outcome. We collected data from 1st March 2019 to 31st August 2019. Number of samples collected was 16,562. Number of hemolyzed samples was 6. Venipuncture failure 7. Number of clotted EDTA blood 9. Total number of errors were 22 out of 16562. Total number of errors 22, and these were the distribution of errors to percentage defect. Out of 16562, 22 errors were there. So these were converted into defects per million opportunity and then to sigma value. The sigma value which we got after applying defect per million opportunity, 4.5, 4.9, 4.8, 4.7. in this data. Then we analyze what is the reason of these happening in our lab. These were the reasons: improper training or poor mixing of blood. Therefore, we were getting this clotted EDTA blood, or vigorous mixing resulting in hemolyzed sample, and venipuncture failure because of improper training. For this, we conducted training on various aspects: how this sample shall be mixed, how this sample shall be collected, correct mixing of sample, proper storage of sample. So we trained people for everything, and whether they have understood the concept or not, for this we did post-training evaluation. Our action plan was regular training and competency evaluation. It's not one-time training. We will conduct training regularly, and we will monitor our environment also. Sigma metrics will be reevaluated after 6 months, and our aim to achieve sigma above 5 in pre-analytical phase. This was decided, and when we checked the 6 sigma again, so there was significant improvement in the 6 sigma. So when we say 6 sigma, what is required? First thing is you are calculating. We are identifying the problem. We are defining how we will identify the problem. Then, based on data, we are saying, okay, some problem is there. This we are getting by collecting data. Then we are converting this practical problem to a statistical one. We are finding out when we are analyzing, so okay, this is the situation, and a solution required. And then we are documenting that solution to control, to improve in the 6 sigma area. So as we discussed, first we identified if there is 3 analytical problem, out of these, what were because of venipuncture failure or hemolyzed sample or clotted blood, what is the reason of these, what is the action required. Then we took the action and we monitored our action, and after 6 months there is significant improvement. So when we analyze all these things, so we are able to improve in these areas. What we need to do in our setup, we have to see what are the areas, whether it is process outcome or process variation, where 6 sigma can be applied. It may be waiting time in the lobby. You are saying if waiting time is more than 30 minutes, this is not acceptable. We want to keep this waiting time less than 30 minutes. Now you are identifying out of total patient in how many cases patient has to wait for more than 30 minutes. So how many situations, out of how many possibilities, and you are calculating 6 sigma. So that way, 6 sigma is a tool. You have to see how you can use this. Now tool is in your hand. You have to use, you have to measure your data. You have to analyze your data as we discussed, and we have to take action to improve in the area and monitor you are able to maintain that improvement. These are the different wastes in the laboratory: incorrect data entry, overproduction, Suppose you are generating one report, then that report is misplaced. You are creating report again, or some IQC data, you have not acted upon that data, or you are storing multiple copies. If suppose one copy get misplaced, we will use another copy. In transportation, extra step in the process for distance. Patient is waiting for billing, for sample collection, for report dispatch. Inventory transactions not processed. Non-utilized talents. Somebody is talented, but talent is not utilized. We are keeping different person for each activity. So that way, what happens? Unnecessary wastage and burden on the laboratory. If everything is taken care of, what will happen with this Six Sigma tool? There is cost saving and resource management, and we can design appropriate QC strategy. Final result is your peace of mind and confidence, and customer will feel more satisfied. Thank you. Okay, once again, good morning all. This pre-examination or pre-analytical, generally when we quantify something, we divide our steps as pre-analytical, analytical, and post-analytical. When we see laboratory in totality, we use this term pre-examination, examination, post-examination. This histopathology requirement related to sample collection or in peripherals view. It is not pre-analytical, it is pre-examination. For glucose, urea, hemoglobin, it is pre-analytical. Estimation is analytical, but for histopathology slide examination, it is not analytical part. The pre-examination covers everything. So I purposely wrote this as pre-analytical so that I can discuss this aspect also. With automation, what we have achieved, good equipment, and we are more confident about the performance of your laboratory. But we have to remember one thing, quality of our result is only as good as the quality of the sample received in the laboratory. If the quality of the sample is not good, we cannot generate good reports. 80 to 85% errors occur in the pre-examination phase only. You can see garbage in, garbage out. The quality of the sample should be good for each and every test in the laboratory. Medical errors are responsible for 44,000 to 86,000 deaths every year. I'm not saying these are laboratory errors. These are medical errors, which is the eighth leading cause of death. And somewhere, sometimes laboratory also contributes to these deaths. Not very significantly, but still it is contributing. And what we need to do, we as a laboratory person, we have to reduce that possibility. Incorrect test result, it will result in wrong decision. Delay in notifying abnormal result, So again, it will create problem. The accuracy of the result and turnaround time of the result is very important, and this is expected from the laboratory. Directly affects patient care, directly affects patient outcome, it influences therapeutic decisions, it impacts patient length of stay in the hospital, it also affects cost. If there is error unnecessary, the patient may have to undergo some more tests, more cost is involved, or some unnecessary procedures. All these things influences laboratory efficiency, reputation, and also their market position and share. Whenever there is any error, whether it is pre-analytical, analytical, post-analytical, we have to understand one thing. There is wrong system in place. It is not because of the wrong people, and we have to improve our system. And if we want to detect error in any system, we have to develop non-blame culture. Otherwise, people will not come forward to tell you the errors which has resulted in the laboratory. What is pre-analytical phase? Before testing, every aspect of your laboratory activity is considered as pre-analytical or pre-examination, from test ordering to actual testing. When this test starts, examination part starts. Generally, we focus more on the analytical part. As a laboratory person also, we have very good equipment. It is the only one in the whole country or in the whole city. Or we are participating in IQC or participating in EQUAS. And people also say, I perform every test personally. Who is collecting sample? God knows. Because samples are collected in different collection centers. How they are reaching, who is collecting, rather than concentrating on that, we are concentrating on analytical part. And if a nursing home is collected sample, a clinic is collecting sample, they think if there is any error, it is because of laboratory. So we have to understand this pre-examination is very important. If test is not ordered correctly or sampling is not performed correctly, it results in error. What is important? Choosing the right test, collecting at the right time, collected by the right method, using the right tube, after right patient preparation, using the right specimen, storing it in a right manner, transporting the sample in a right way, keeping in mind within reasonable time frame at appropriate temperature, keeping in mind safety of the person who is transporting those samples as well as integrity of the sample, and periodically review your transportation system, proper labeling of the sample. For each different aspects, you shall have documented information to the person who is collecting these samples. And now ISO has prepared one document also, ISO 20658. It is for pre-examination because samples are collected at different places and transported to far-off places. So we shall have proper guidelines to handle the pre-examination phase. Examination phase will be handled by the laboratory. They are trained in that. But this pre-examination phase is very important. And why it is important? Because this is not in lab control. It involves patient, it involves nurses, it involves doctors. And if we are carrying out these properly, we can minimize unnecessary repeat work. So if we are able to reduce these errors, definitely patient will feel more happy and many burdens are reduced. In ordering, the clinician should know what to order. If a Vidal is ordered with 2-day history of fever, or a test is not interpreted correctly, infective endocarditis is ruled out because based on one negative blood culture report, so that is not correct. And what all tests laboratory is performing, wherever you are sending sample to, what is their schedule. Your nurses, if collecting samples, they shall be trained and they shall have proper information about the different tests. Certain blood sample need to be processed immediately, like CSF. They should understand ABG sample, how it is to be collected and how it is to be processed, how frequently a test need to be done, how these results will be used, and for any query, consult laboratory person. So, what is required? Laboratory has so much responsibility related to pre-examination. Don't neglect this part. Regularly talk to clinicians who are sending samples to you. How a particular sample shall be collected, what are the tests to be ordered in a particular situation, which are meaningful for them. So you have to educate your staff, you have to educate your clinician. Clinicians, they have to educate their staff, or their staff also has to be educated by laboratory people. So suppose fasting is more than 126, or PP is more than 200, or a random blood glucose is more than 200. There is no need of glucose tolerance tests. Similarly, you should know what are the guidelines for lipid profile, vitamin D status, hypercalcemia, what is the test to be done. For hypocalcemia, it is 25 hydroxy vitamin D. For hypercalcemia, 125 dihydroxy vitamin D. Intact PTH to assess parathyroid function. Similarly, a PSA shall not be ordered after a PR examination or urinary catheterization. TSS is sufficient to screen hypothyroidism, but for hyperthyroidism, you need FT3 and FT4. And if there is some abnormality, so for monitoring thyroid function, for hypo, it is TSH, for hyper, T3 and T4. And minimum gap 2 to 3 months. It is not like that you have started thyroxine and you're again testing patient after 15 days. After 2 to 3 months. And it takes 1 month for the thyroid hormones, especially TSS, to return to baseline value after stopping thyroid medication. So, no need to stop medication on the day of the test. If a patient is coming for thyroid hormone, there is no need of stopping drug. It is meaningless. Patient identification is very important. At least 2 identifiers, name and lab ID, and any CR number. Label sample used in the presence of patient after collecting sample, not later. It is not like that. You are collecting 2-3 samples and then you are labeling the sample. And information on the test request should be similar to label. And do not draw extra unlabeled tubes if it is required, and you are not labeling those. It will create unnecessary confusion. And the person who is collecting sample, only that person should label the specimen, not someone else. You can use barcoded labels if your resources allow. This is a good practice. These days, we are using tubes in this. These preservatives are already added, but if it is a small setup, you are preparing tubes to use proper additive in proper concentration. And also you have to see in certain tests, it may exercise or posture may affect some result. What is the exact timing, like for cortisol, for filaria, patient preparation for the test, long-term tourniquet shall not be there in what are the tests where tourniquet shall not be used, how sample shall be collected from IV lines or catheters, what are the guidelines, avoiding how this clot shall be avoided, avoiding hemolysis, type of specimen required in a situation, use 70% isopropyl alcohol for the cleaning, and let it dry before sample collection, because some small traces of alcohol causes hemolysis. If you are estimating blood alcohol, don't use alcohol swab. Use some other cleaning agent like benzalkonium chloride. Tourniquet shall not be there for more than 1 minute. And as soon as this syringe enters the vein, tourniquet shall be released. It causes increase in certain analytes. This fist clenching also creates increase in certain analytes. Avoid tourniquet for potassium or calcium or ammonia. Even CK and pyruvate are increased because of tissue injury and stresses. Sorry. Wrong tourniquet increases all these analytes. We have to understand the long tourniquet shall not be there. It creates some problem. And use needle of appropriate bore size. If you are using very fine needle, it may cause hemolysis. And if you are transferring blood from syringe to a tube, First, dislodge the needle from the syringe. Generally, we are not using capillary blood and arterial venous blood values are same. Whole blood and serum plasma values are not same. Whole blood glucose is 10 to 12% higher than the plasma glucose. So in glucometer, you are using whole blood glucose. And when you are estimating in your machine, it is plasma glucose. Brisk walk or vigorous exercise also affects certain analytes. So there should not be any heavy exercise. Even brisk walk for 5 minutes. Sometimes some patients are in the practice they are going for morning walk, and while coming from the morning walk, they are coming directly to laboratory for this sampling. So we have to understand at least 15-minute rest should be there, because it increases certain analytes, increases certain hormones, it decreases certain hormones and analytes. No physical exertion during an oral glucose tolerance test. Person should remain seated. It is not like that if person is providing one sample and going home, coming back from home, unnecessary stress, and it affects sugar. Some glucose consumption, and because of stress, some increase in the glucose. Certain analytes exhibit circadian rhythm, sleep-wake rhythm. There is cyclical variation. Some analytes, they have pulsatile pattern of secretion in burst in response to physiological stimuli. Diurnal variation, day-night rhythm. This burst for pulsatile, insulin, prolactin, growth hormone, testosterone. For insulin, glucagon, C-peptide, fasting sample is best. Food alters their level. Prolactin, fasting, person should be fasting. Levels are very high during sleep and early morning hours. And for prolactin, 3 samples shall be collected, one fasting, and then after 20 minutes, then again after 20 minutes. Certain hormones which are secreted in pulsatile manner in case of parathormone, always request for intact parathormone and serum or EDTA sample is collected. For aldosterone, early morning sample, testosterone, highest early morning, decreases by evening, decrease after food, dehydroepiandrosterone, EDTA plasma sample preferred. So I am not reading each and every slide. What I am emphasizing here, for everything, you shall have guidelines. You have to create your sample collection manual, because this information is given in every book. What I want to emphasize upon, all this information is important, because people who are collecting samples, your resident doctors, your nurses, phlebotomists, they will not read all these things. So when you are preparing your sample collection manual, you have to address all these things in sample collection manual, and this sample collection manual shall be available at the sample collection station, in sample collection centers or nursing station, so that samples collected for a particular test remains meaningful, and proper guidelines how this sample shall be transported. If this TSH is highest at 2 a.m., between 2 a.m. to 4 a.m. and lowest 5 p.m. to 6 p.m. Sometimes a patient is coming to you, there is variation in the result. So this may be because of some variation in the time of collection. So for every sample, lipid 5, minimum 12 to 14 hours fasting. Patient should be seated for 5 minutes, should not have consumed alcohol for last 2 days, and vigorous physical activity. So like this, for every sample, we have to be very careful. Fasting glucose minimum 8 hours and maximum 12 hours of overnight fast, postprandial 2 hours after starting the meal. For oral glucose tolerance test, again, you need proper guidelines. For glucose challenge test, there is no need to fast. 1 hour sample after 50 gram glucose. For GTT in pregnancy, again, you have to provide proper guidelines to the person who is collecting those samples. Similarly, for different hormones. If you are collecting sample for 24-hour urine, then what are the guidelines? You are discarding first sample, and after that, all samples are collected in the container, and you're including last sample also. And this shall be transported to the laboratory within reasonable time frame, and appropriate preservative shall be added in this urine sample. For different type of tests, what are the different precautions that need to be addressed in your sample collection manual? Different type of tubes. These are color coded tubes, and what is the purpose of a particular tube? What are the different type of samples, different type of analytes, and how a sample shall be collected for a particular type of analyte. What shall be the order of draw? This is important when you are collecting multiple samples. So paste this order of draw in your sample collection area. Because if it is not followed correctly, you are collecting directly from the vein in the tube, then it may affect your result. As we discussed, quality of result is only as good as the quality of the sample received. And how this sample shall be mixed. This is also important. You are collecting sample and how you are mixing these samples. This is also important, and this shall not be done too vigorously. You are only tilting this your tube 180 degree and then again bringing to same position. Gently invert the tube 3 to 4 times after collection. What is one inversion? A inversion is one complete turn of the wrist 180 degree and back. Holding tube upright, gently invert 180 degree and back. What I want to emphasize upon through this slide, your instructions should be as clear as possible so that there is no compromise in the pre-examination phase. This is very important aspect. You are trained in your laboratory practices, but samples are collected by people who are not trained in laboratory. So how they are collecting samples, they shall have proper guidelines. And this sample shall be mixed immediately, because otherwise sample may clot. And don't shake too vigorously and check for clot. This I have mentioned again, whatever I discuss with you through that photograph. Generally, these days we are using prepared tubes. Previously, we were preparing, so we were adding a fixed quantity of anticoagulant to a particular tube. But these days, we are using already prepared. But if you're preparing, suppose you are in primary health center, district hospital, you are not getting these tubes, then you have to use proper guidelines. And we have to understand sometimes these vacutainers also can cause some interferences, zinc contamination, gel tubes not suitable for trace elements. Vacutainer method is ideal because there is proper blood anticoagulant ratio. It avoids hemolysis. Adequate specimen is collected. But if non-vacutainer tube is used, proper concentration and volume of preservative or anticoagulant should be used. How you are collecting samples from IV lines. If a patient is receiving IV fluids in one arm, sample shall be collected from other arm, or distal to the area where you have placed the cannula. Or if line is heparinized, flushed with 5 ml of saline, then first 5 ml blood is discarded, and then you are using with other syringe sample for any analysis. Do not overfill tubes. And we have to avoid hemolysis. It affects our results. And one important aspect, when you're cleaning with alcohol swab, let it dry. Don't be in hurry and use needle of appropriate bore and avoid vigorous shaking the tube. And do not force blood from syringe to tube. Remove needle and transfer slowly. Separate serum after it clots, after this blood clots as soon as possible, because delayed separation affects certain aldehydes. Maximum within 2 hours, it should be separated. When you are centrifuging, it shall be centrifuged properly, and it should standardize this system of centrifuging. Transport in ice certain samples. Again, what I'm saying, you shall have proper guidelines for the collection of different type of samples. Do not store whole blood. Separate serum or plasma and then store in cap tube at 4 degrees centigrade for up to 48 hours. And if you're freezing sample, so it should be first thawed. Hello. हाँ ठीक है अभी आ रहा हूँ. And it should be first thawed and then tested. Do not refreeze these thawed specimen. Certain analytes are affected by the storage, like LDH, SGPT. What we need use of well-written procedures and policies. This can reduce pre-analytical errors. Train laboratory staff and nursing staff inform physician about uncontrollable pre-analytical variants which affect results. What we need a lot of emphasis upon this pre-analytical part, and I will suggest all of you, if you can get a copy of 20658, develop your sample collection manual pre-analytical phase, whether you are going for accreditation or not, for the to improve your sample collection system, right?
Morning, everyone. I am Dr. Reenu Goyal. I'm Senior Consultant and Head of the Department of Lab Medicine, Sitaram Bhartiya Institute of Science and Research, which is in New Delhi. I am pathologist by profession and lead assessor NABL. This is the place where I work, and directly we come to the topic, which is a topic of the day is quality indicator. First of all, I would just like to start with the proper definition, although I know this is difficult to understand, but not important to learn by heart. So what the definition says, according to ISO 15189-2022 terms and definitions 3.26, the measure of it is the measure of degree to which large number of characteristics of an object fulfills the requirement. So in this definition, I can explain you by saying that object means if we take some part of our examination phase. For example, if I say, I will talk about pre-examination. Just a second. Yeah. So if I say that I am taking pre-examination phase, so what are the characteristic of object has to be defined. That what am I wanting in my pre-examination phase to be measured so that it can reflect my quality of results, quality of process, pre-examination process. And when I measure it, by measuring, I will set a target that I have to reach up to this point. So when I fix my target, it guides me that I have to improve or I am already good. So that is how I can assess. Just wait for a second. Yeah. Yeah. So this is how the definition can be explained. Am I audible? Yeah. So this is how this definition can be explained, that what is the meaning of this definition. Another this thing is the term quality indicator refers to a systematic measurement. Basically, we have to measure everything which is systematic. So for that, we have to define the thing first, that where we want to reach, what do we want to measure. So it is systematic measurement of the process intended to provide information about the quality of a system. So ideally, every laboratory aspect should be objectively measured and it should be done regularly. When I talk about 15189-2022, the clause 5.5 also, it talks about that laboratory should have objectives and policies defined. What is objective? The overall goal of the laboratory. The standard has defined that how objectives are to be set in a laboratory. That is a different topic, but why it is important here? that objectives guide us towards the defining our quality indicators. So when objectives are defined, quality indicators shall be directed towards meeting these requirements. For example, if I say my objective is to have 100% customer satisfaction in my laboratory. So for meeting this requirement of 100% customer satisfaction, I will require certain quality indicators. For example, customer need is timely collection, less waiting time. The cost should be less. The turnaround time should be minimal. So this is my customer, and good quality reports, accurate and correct reports. So for meeting these requirements, I have to define my quality indicators based on that I will monitor the waiting time, I will monitor the turnaround time, I will keep the competitive cost, and I will maintain good quality in my laboratory reports in terms of accuracy and good precise reports. So these become my quality indicators to meet this objective of customer satisfaction. So likewise, we have to define certain indicators which standard tells us. The type of quality indicators which can be measured in lab are number of unacceptable samples relative to the total number of samples received. This standard says that we should start noting down the number of errors in laboratory during registration or during sample receiving, number of corrected reports, the rate of achievement of specified turnaround times. So this standard guides us how. In again 8.8, the standard says in the evaluation term that 8.8.2, the quality indicators has to be defined by the laboratory. So lab shall have a process of monitoring quality indicators, which includes establishing the objectives, methodology, like we have to define objective, what we want to measure, the method, how will we do that, the interpretation of that, the limits, our action plan, and duration. So these are few important points on which our quality indicator should move. The effectiveness or performance of all quality indicators is periodically reviewed to ensure that we are continually improving or not. So now we come to what is the purpose? Why are we doing this? So as I have told you, that to meet the requirement of standard 1, to meet the our objectives 2, and to meet our customer needs. These development of quality indicators are important. But methodically, if I want to tell you that effective quality indicators may be used for one or more of the following purposes, which is monitor specific normally stable functions, the functions which are normally stable, but these are specific to the laboratory. We want to monitor that. Another thing is that we want to monitor complex processes that involve multiple inputs or multiple sequential activities. If I say pre-examination process, it is a complex process because it involves multiple inputs, because samples are being collected from multiple sites, and there are multiple sequential steps in terms of starting from order of the test to receiving of sample in the laboratory. There are multiple steps like ordering of test, then sample drawing, then sample transport, storage of sample before transport, sample transport to the laboratory, then acknowledging the sample in the laboratory, storage of samples before processing. So these all constitute a part of pre-examination process. So it is a complex process where at multiple steps we can define the quality indicators, monitor the effectiveness of planned improvements in the operations. The operations like home collection process. This is the operational part. I want improvement in my planned home collection process. So I can define quality indicators in that. Explore potential quality risk. If I have some risk in my laboratory reports, the post-examination process that I want, I do not have the interfacing system in my laboratory, and because of that typing errors are more. So I know that this is a potential risky area. I want to improve the quality of my reporting. So I will define indicator in that. how and when to choose quality indicators. So this is very important step, that how to choose and when to choose. Otherwise, we think that everything is important, and we think that we should include everything, but it is very difficult to monitor each and every step. So we have to first think that these are the improvement areas, and these are already which we have already gained success. So if you have gained success in certain area, do not keep on monitoring that. You can stop that. So there is no generally agreed upon process for selecting an optimal set of quality indicators, but some quality indicators are required by law, by regulations like accreditation bodies, and some contractual agreements. For example, the requirement of internal QC monitoring of analytical systems, the requirement of ECAS, it is required by our accreditation bodies. For this, we have to monitor. When not required by external agencies, quality indicators are chosen by leadership. So when it is not defined by external bodies like accreditation agencies or requirement by law, so our leadership definitely would like to lead us towards a quality improvement area. So leadership guides us based on organizational goals, the risk management strategies, the review of data and complaints, the client recommendations, and subjective assessment, that these can be our quality indicators. What are the inputs which we consider while developing our quality indicators? Like customer concerns. Customer concerns, as I have discussed, are satisfaction, timely reports, estimate of the test or procedure, maybe timely discharge or timely availability of reports. There may be some societal goals, like in terms of safety, patient safety, employee safety, the effectiveness of our planning, some patient-centered care, like venipuncture, number of venipunctures should be less, timeliness and efficiency. Based on this, we can decide our quality indicators. Laboratory vulnerabilities, like high-risk patients or high-risk processes are there. Some failure-prone examinations are there. So for that, we have to develop quality indicator like IQC or ECAS. Then, depending upon the path of workflow, pre-examination phase, examination phase, and post-examination phase. So this we can segregate so that it takes us less effort to define that where we should go for our quality indicators. So when we have segments in our mind, it becomes easy for us to decide on something. Inputs to consider when developing quality indicators, again, there are in quality system essentials. If we talk about CLSI guidelines, they have defined 12 quality system essentials, which are document and record, organization, personnel, equipment, purchasing, inventory, process control, information system, assessments, external and internal, process improvement, customer service, facilities, and safety. So these are essentials, and we can choose any one of the fields or multiple fields out of these essentials to select our quality indicator. What are the activities when we develop quality indicator? First of all, we have to define a definition for the indicator. So there has to be one operational definition. Operational definition guides us that what are we trying to do. Definition gives communicable meaning to a concept or an idea. It is clear and unambiguous. So indicator identification tells us the purpose of indicator, authority, and the scope. Data collection strategy should be defined, that who will be the individuals responsible for that, frequency of measurement, data sources, sampling scheme, validation studies, how will we validate the indicator that we are going correctly, external references to be used, calculations and data manipulations to be defined, and what form is to be presented should be defined when we set that. Then a very, very important thing, that target or action threshold is to be set before starting measuring. Then risk assessment is to be done. what are the activities while using quality indicator is that we have to check whether implementation is there or not. For that, what we need to do, we start with a pilot trial. We have defined that we will monitor turnaround time of our laboratory, that every urgent stat report should be released within 1 hour. So for that, I have to first define that this is my target area. This is my quality indicator definition that I want to, the laboratory will 90% cases, in 90% cases, the stat report of my laboratory will be released within 1 hour. And the time limit to this is 6 months. Within 6 months, I will achieve. So this is my operational definition of the quality indicator, wherein I have defined the purpose and who will be responsible for that. The lab director will be responsible for that. Where will we collect this data? The stat samples in the laboratory, the inputs will be from emergency, from ICU, from the wards. So this becomes my area. Frequency of measurement, that will be, I am going to monitor this on daily basis. The data sources will be from laboratory information system and the nursing counters. So likewise, I have defined. So initially, I will check this, whether the indicator is too tight or correct. For that, I will like to have a pilot trial for 1 month. Before finalizing, I will try by PDSA or PDCA that what are the improvement areas if I have said that, and will collect data. I will analyze data and identify performance trends and act upon that, whether continue or stop based on that pilot trial. Identify opportunities for improvement or remedial action. If there is some scope of improvement, I will try to find out the root cause analysis and corrective action to do that. Quality improvement strategy should be applied on that. So this is how my quality indicator should be defined, monitored, analyzed, and finally acted upon. So there are few representative quality indicators which can be guided, which can guide us towards the definition, towards defining the quality indicators for our laboratory. Maybe it is cost system related, like cost benefit ratio. For example, cost of the laboratory test per patient outcome. We can have one quality indicator on that. This will satisfy my customers as well as the leadership. Customer satisfaction in terms of patient or physician satisfaction with the laboratory services, we can define what all criteria we want to put in customer satisfaction, like waiting time, like correctness of report, like turnaround time. Safety, for example, needle stick injury occurrences, you can have this indicator in your laboratory. Verification of physician orders to results of point of care examinations. Patient waiting time monitoring. In pre-examination phase, you can have accuracy of patient identification, adequacy and accuracy of sample information, adequacy of bone marrow aspirate if it is done, appropriateness of sample container, the correct sample labeling, examination order accuracy and appropriateness, patient consent, phlebotomy success, number of sample transportation. In examination phase, likewise, accuracy of time and timeliness of reports, correlation of fine needle aspiration diagnosis and final diagnosis, effectiveness of rules to detect abnormal samples, like the Westgard rules we apply, the CV monitoring. EQA, we can have one quality indicator, what is the performance of our parameters in external quality assessment. Like if we have multiple equipment, we can have this quality indicator of instrument to instrument correlation of our reports, QC process, the IQC, or some other processes. So one quality indicator is vacancy of technical staff. This is some administrative indicator that is the attrition rate too high? Very, very important indicator, administrative indicator, wherein it guides us that why so much of attrition rate, and is this some specific reason or purpose or person involved behind that, And this will help us in improving the resources, the manners, the waste in reducing our wastage. Surgical pathology slide review program, sample contamination we can check. In post-examination, consistency of critical values reporting, any corrections in surgical reports, pathology reports, patient satisfaction, report delivery, turnaround time, proportion of corrected reports, compliance with internal turnaround time standards, emergency department